Julie is too.
Well, let's not waste any more time. We got a lot of good stuff to get to here. First off, I wanted just to say welcome to everyone that's joining us. Welcome to all our participants, or should I say Bootcamp recruits, to our virtual community event, Skin Safety Bootcamp, in honor of Skin Cancer Awareness Month. Before we get started, I'd like to highlight a few important tools within the web conference software. You should be seeing my screen now. That looks like a conference window. And let me go ahead and get my laser dot up to make it easier. In your conference window, you'll see a few main commands, which are the circular icons on the bottom of the screen. Firstly, the icon with a microphone in it controls your microphone function on and off. Next to the microphone is the video button, which controls your video on and off. Both of these icons should be red as they have been disabled upon entry to the chat. If you guys want to be on video, that's perfectly fine. Just know that everyone else can see you. To help avoid unwanted distractions during the conference, please keep yourself muted unless you're prompted to in the Q&A session. Next, we have the participants button here, which opens and closes the participants tab. And we have the chat function here, which is particularly important. The chat function is going to be your main way to ask questions or to speak up during the presentation. So go ahead and put any of your questions as you go along within the chat bar, and we will go ahead and call on them as needed. If you would like to speak your question, you can say, I'd like to speak my question, and we'll do our best to get back and forth going there. Lastly, there's a few options for your viewing window if you'd like to mess around and find your favorite way to view your viewing preference. But otherwise, I think we are good to go. I will go ahead and pass this over to Dr. Leachman, and we will get this boot camp on the road.
Okay, let me share. Hopefully I'm sharing my screen now, and I will start. Here we go. Can you guys see, can you see my screen?
All good.
Okay, so now can you see my laser pointer?
We can see your laser pointer.
Even better,
yeah.
Even better, good. Okay, so this is May, and as we know, one of the reasons for Skin Cancer Awareness Month being in May is because it's the time when everybody starts to really get out in the sun, and it's a really good reminder that we need to protect ourselves. And so it's a perfect time, I think, for a boot camp. And so we're going to talk today. I'm going to give you the agenda, what we're going to talk about throughout the rest of the round table. First of all, boot camp, the boot of the boot camp. And what I want to do is basically arm you with real facts. So it's the education. It's getting you guys informed about what the real facts are. And we're going to let's see, we're going to have a question and answer after that boot, you know, the whys of why we're doing what we're doing. We'll have a question and answer session, and you guys can ask anything that, like, for example, if there's any confusion about any of the melanoma data, happy to answer it. Julie and I both can do that. Then the next section, so that's the first section. We're going to be broken into 3 sections. The second section is on primary prevention. In other words, getting at the root cause. And the root cause, the main thing that we know about currently that causes melanoma is ultraviolet light, the sun. And so we're going to have a section that's on that. And then we'll have another question and answer session that's on photoprotection. And so you can ask all your questions about that. And then the final section that we're going to have is on early detection. So not only can you prevent melanoma with prevention, but you can also keep it from being life-threatening by, if it does develop, catching it as early as possible, finding it before it's too late. And then we'll have another question and answer session about what tools are available to help you catch it early. And of course, we're going to have some fun things in between, like little raffles and things like that too. So here we go. So preventing skin cancer, the why. You know, what does a sunburn do? Is it is it just because you've got red hot skin? No, it's because of DNA damage. And what happens is that the sun's rays come in and cause DNA damage in the cells that can then turn into cancer. In the case of melanoma, it's the melanocytes that turn into cancer. In the case of non-melanoma, like squamous cell carcinoma or basal cell carcinoma, it's the keratinocytes that turn into the cancer. But that's what the sun does. Is it's like they're like little packets of energy that come in and change the DNA so that it doesn't work properly anymore. And it's really not. I think one of the common misconceptions is that that you can fix it once it's healed. That damage is gone, and that's really not true. Your skin's damage is a cumulative effect over time. And it's also dependent on how your skin reacts to that damage, how well it repairs it, and that's dependent on the genetics that you have. And then we've got cosmetic concerns that happen from sun and from all the lifetime of living. And preventable cancer is what skin cancer is. So these are sort of some of the sections I'm now going to do a little bit more detail on. So here we go. Oregon has a skin cancer problem. And I think that's not commonly known, actually. And I think everybody on this call may know that, but they've probably learned the hard way, either by having some experience themselves with skin cancer or in somebody that they know or love. And what we really need to see here is that so I like this comment, cloudy, rainy Oregon can't have high rates of skin cancer, can it? Of course it does. So this is some latest statistics that just came out in response to May being the Melanoma Awareness Month. It just came out like last week from the CDC. And so you can look here, here's the data source from the CDC. And this is really nice because it's a full 10 years worth of data. So this is not, the data we're talking about here is not like just 1 year and a fluke. This is an average of the 10-year data to the latest data we have, which is in 2017, because it takes a while to get all the data entered. And look at what the numbers are. 6th in the rate of new melanoma cases for both male and female, and tied for 7th in the rate of death. So skin cancer, particularly melanoma, is a problem in Oregon. So what does sunburn do? So here I've got, this is sort of a schematic of the skin, and this is the surface of the skin and the little hair follicles coming out. And as you can see, it's a really complex organ, right? There's a lot of stuff in there. There's an epidermis and a dermis, and below the dermis, the hypodermis, there's blood vessels and sweat glands, and there's oil glands, and there's capillaries and venules and all kinds of stuff that makes up the skin. But if you look up here in the epidermis, right here along this, between the epidermis and the dermis, is this what they call the basal layer. And this is where the melanocytes live, is right in here. And they feed the pigment to the keratinocytes that give you a tan. And what's important to realize about ultraviolet damage is I mentioned that UVA and UVB come down. They're like little packets of energy that enter the cells, and in the case of melanoma, enter the melanocytes, damage the DNA. And the first thing that the melanocyte does in response to that is make more pigment. So when you get a tan, what it really is it's your melanocytes screaming out, I've been damaged, I've been damaged, I need to protect myself, and it puts all the pigment in to try to protect itself, and that pigment goes in and covers the nuclei of all of those keratinocytes to try to protect it from more damage. Now, what's really interesting, though, people think, oh, well, I can tell when there's UVA and UVB. I can tell when it's around because it's not bright outside, it's not sunny. And the fact is that UVA and UVB, the whole point is it's truly invisible. It's not perceptible to human beings. Human beings cannot see UV light. They can't feel UV light. It doesn't feel hot. It doesn't feel tingly. There is nothing that you can as a human to feel it. Can we, yeah, there we go. Thanks, Patrick. So we can't feel it. If we can't, the only clue you have is that with UVB, it can cause a sunburn after you've been in it for a while. Sunscreens block it, right? It's invisible, it tans, it causes sunburn, and sunscreens block it. UVA is different. It's also invisible. It can tan you, but it takes a lot longer. It's a lot slower to burn you, right? But you can see it goes deeper into the skin and damages this dermis, and that's what causes wrinkles or photoaging. Now, some sunscreens block UVA, but not all sunscreens. You have to look for the ones that block UVA. So sunburn doesn't come from the heat. It damages the skin cells and causes mutations in their DNA. And then, of course, the damaged cells are the ones that go on to get more and more damage. As they get more and more damage, they ultimately will become a skin cancer, and they have uncontrolled growth, and they can grow and they can spread to other parts of the body, and that spreading and setting up shop and then growing and replacing the normal structures is what causes you to die from any sort of cancer. So it's a cumulative damage, as I mentioned, and it's important to know that about it's estimated that 40 to 50% of the total UV damage that happens in an individual happens before age 20, but that doesn't mean that you're not continuing to get additional damage after that period of time, and once it's happened, there's no way to reverse it. So I want to show you sort of I mentioned, I think, maybe that, that melanoma, really, when you look at what causes melanoma, it's about 50% genetic and 50% environment, but there's a lot of overlap. And so what I'm going to show you here, this is a really beautiful family with red hair, and this is a family that might be at risk for having a family history of melanoma because they have shared family traits that put them at risk, like red hair and blue eyes and fair skin and freckles and all of those things that make their skin more vulnerable to getting that damage that causes the DNA. But fortunately, those elements, they're genetic, right? You can pass on red hair and you can pass on blue eyes and all of those things, but they're not a really high risk gene. So they combine to form a higher risk, higher probability that you might get a melanoma in that family, but not a huge high risk, right? This is different here. This is a pedigree. So this is a pedigree that I'm showing of a family that I took care of when I lived in Utah. And this family had a mutation that they carried in a gene called P16. And in that case, anybody who got that gene that had the mutation in it, that inherited it, had a very high risk of getting a melanoma. And you can see in this case, they're at risk for getting both melanoma and pancreatic cancer. The pancreatic cancer is in green, the melanoma is in red, and here this individual had both. And so you can see that it's an autosomal dominant effect. So if you get one copy of this, it gives you that really elevated high risk, and that the risk is about a 76% chance that you're going to get a melanoma if you live to be 82, 84 years in that family. So that's the difference. So I guess the point is I just want to make is that there's different kinds of genetics that are associated with melanoma. There's the genetics that are sort of the everyday genetics that place us at a little bit higher risk, and then there's the genetics that run in families that make you at really high risk. So the other effects of UV light are cosmetic, and I think this is a great photo, isn't it? Isn't this a beautiful photo? So I think you can all appreciate that this side of his face is much more wrinkled than this side of the face. And remember I said that those UVA rays are primarily the ones that go deep enough, and they go through windows of cars. And this is a truck driver, and you can tell that he basically had much greater wrinkles on the one side where it was more exposed to the UV light than the other. It can also cause dark spots and just basically that photoaging. So protecting yourself from both UVA and UVB not only protects you against sunburn, protects you against the damage that you're getting, and it protects you against the wrinkles that you may have a chance to get. So the important part about skin cancer is that it is preventable, and we can do something about it. So what about catching things early? That's the other side of the coin. Even if you aren't able to protect, if you're in one of those families and you get melanoma anyway, you can still catch it early enough so that it doesn't get you, right? And so there's important points that it's cosmetic and loss of, well, I'm just going to go forward here. So early versus late treatment. So as you can see, the deeper a melanoma gets, the more chance, the more access it has to those blood vessels, the more chance it has to be able to spread, and the more skin that needs to be removed. So the later stages require larger and more procedures. They may require a sentinel lymph node biopsy. They may require follow-up care, and they can definitely become life-threatening. So this is the data. This is the statistics. So if you catch melanoma before it's had a chance to spread while it's still only in the skin, your chances of being alive in 5 years is 98%. If you don't catch it until after it's spread, then no matter what treatment we apply, your chances of being alive in 5 years is about 24% right now. Now, I want to say it's getting better. With better treatments, it's getting better. But it's still, this is the latest data to date, is about 24%. That was in 2017 when most of those really good immunotherapies started out really being available to everybody around 2014. So the earlier melanoma is caught and treated, the less likely it is to kill, and in situ versus metastatic growths are better. So I think we're ready for the first raffle. Patrick, do you want to do the raffle?
Let's do it. We'll go ahead and get our first raffle out of the way, and then we'll get to some of these great questions that you guys have. Just so you have an idea of what we're rocking with here. We're going to have 5 Columbia UPF sun protection hats. We're going to have a small sunscreen gift bag with several items in it, and then we're going to have a large sunscreen gift bag here. And we'll just go ahead and go through these and get some winners here bright and early. I'm going to put this over here. This is the name of everyone who's joined the conference, so everybody's got a chance to win here. So this one is for a Columbia hat. Casey Conrad's our first winner. Shannon Diaz gets a Columbia hat. Dan Crisp is the new winner of a beautiful hat. Shayna Ellis wins a Columbia hat. Our last hat belongs to Melissa Swartz. She works in dermatology. We're going to try that again. Sorry, Melissa. Mora. Okay, for our small sunscreen gift bag. We have Scott. So we'll be taking all these names and bringing them back to our registration list to find people's emails. Anyone who does win is also welcome to email us at waronmelanoma at ohsu.edu. And then for our big gift bag winner, another dermatology member. Sorry, Tracy, we're not giving away to internal people. Laura Skelton. All right, perfect. Congrats to our winners there. Now I wanted to get to some questions. Our first question in the chat, well, it's kind of a two-part question. It's on the data, Sancy, that you presented from the CDC. The first question was if there were studies to figure out, or if they if they knew whether people were born and raised in Oregon or if that's just when or where they were diagnosed. And then the second part of that question was if the CDC keeps tracks of non-melanoma skin cancers.
Second question first, the CDC does not keep track of non-melanoma skin cancers, and that's because there's like a couple of million of them across the country every year. That's how common they are, and so they don't have the manpower and the ability to track that. They're also not reportable they're not a mandatory reporting like melanoma is to the registry, so you can't really track the non-melanoma skin cancers as well. The first question was about, I'm sorry, gosh, what was it? It was that whether they moved here or not. And there's really no way to know for sure, although the numbers that they track are across the entire state. So clearly, as the state grows and we get more influx from California or Utah or sunny places that have higher potential exposure rates, it's possible that some of those are due to those people that have moved in. But what I would say is, if what you're thinking is, oh, it's probably not the sun, I mean, it's probably not really that Oregon is at risk. It's just that the people from sunny places are coming and moving in here, and they're accounting for all of that. That is highly unlikely, because it's also true of Washington State, it's also true of Vermont, it's also true of New Hampshire, and those places don't. So there is something funny going on, and we think that it may be because burning and sun-seeking is such a strong predictor of risk, of the environmental risk, because you burn easier after you've had a winter of cloudiness and raininess, that your skin may be more vulnerable, maybe you're more prone to sunburns, and people seek sun here because they've been sun deprived. And so that's kind of one of my leading hypotheses, but we can talk more about all of them if you want. I don't know, Julie, do you have any other thoughts about that?
I agree with you, Sancy. And yeah, I think Oregon also has a lot of, outdoor activities, sun.
I think we're all a little guilty of sun seeking. And I think one of the reasons that we have an event like this, and something that's always preached within our department, is that no one wants you to shelter yourself and not go out and live active, healthy lives. A lot of the things we're hoping to do here is so that we can do all those things and enjoy being in the Pacific Northwest, but do it as healthy as possible. The second question I have here is, have mutations in genes other than P16 been identified that are linked to elevated risk for melanoma?
Yes, there's a bunch of them now that are known. So P16, which is also called CDKN2A, is one. There's another gene product on that same gene called ARF, or alternate reading frame, and it's almost identical in its level of penetrance and all of that. There's other genes. One of them is called MITF, and that's a big one that controls the growth and the differentiation of melanocytes. There's another one called BAP1, and BAP1 is, and so CDKN2A has a higher risk of pancreatic cancer as well as melanoma. The pattern that we see with ARF is also pancreatic cancer, but sometimes some neurological tumors, especially like astrocytoma. BAP1, which is one that I mentioned, BAP1 is at risk. People who carry a mutation in it are not only at risk for cutaneous melanomas, but also ocular eye melanomas, and also other cancers like a mesothelioma, which is really rare, is in the general public and is associated with asbestos exposure. People who have a BAP1 mutation are particularly at risk for that, as well as renal cell cancers. And I said MITF. MITF is another one, and it also increases your risk for renal cell cancer, it seems like. And then there's some newer ones that we're still learning a lot about, like POT1 is another one, and there's a bunch of telomerase genes. And so telomerase is a protein that puts these little telomeres on the ends of DNA and protects them from aging. And so you might make sense to you that genes that are important for aging. P16 is also a gene that's very important for aging, and that cells that age inappropriately because they don't have the proteins functioning properly, they may also have a higher rate of development of cancer. And so telomerase genes also have been identified as that. And then there's moderate, those are the high risk. Those are the ones that produce the pedigrees, like I showed you. There's a moderate risk, so like having 2 copies of a red hair gene, because it's common, you can get 2 copies and then you get the true redhead. That's about at a 4-fold higher risk. So it's it's not like the big families, but it's not. It's enough that it matters too. So and that's caused by the melanocortin-1 receptor and a few other genes like the albinism genes. So it's pretty exciting, all the explosion of new genes that we know about now that are involved.
And that's why Sancy gives these talks instead of me, because I understand a few of those letters, I think. But we did have a submitted question from before that I think is really, it's a tough one, but I think is really important. And it says, how can I politely tell people of all ages sunbathing near me, what can happen to them in a tactful manner? I think this is the age-old question of how do we pass this information along in a tactful way to the people around us?
I want Julie to answer that. She's much more tactful than I am.
I think that's really tough, just because you're not always sure how much the other person knows and how much they've learned, and, about risky behavior of all kinds, I think. But I try to model good sun protective behavior. So I myself, wear a lot of sun protective clothing, and if I'm going somewhere outside with other people, I'm going to tell them about different types of sunscreens that I have with me and offer them to other people, and sort of talk up everything that I can in that regard. I don't know, Sancy, if you have other thoughts about that.
I think that what I just said, Julie has a very different approach than I do. I'm a Texan. I'm a native Texan. So even though I'm living in Oregon, that hasn't changed my sort of more confrontational style, right? And I think that you have to go with whatever style that fits for you. I think that sometimes people do need, it depends on the person that you're talking to as well. You want to tailor it. If there's some people who only respond to fear. There's some people that you can actually scare by showing them your scar. That's a tactic that some people use. If they've got a scar, they show the scar and they say, boy, I hope this doesn't happen to you. There's other ways that you can provide data. Some people are more data oriented, right? And so, wow, did you know some of that data that I just gave you could come in really handy, right? Did you know that Oregon has the 6th highest rate of melanoma in the country? Did you know that it doesn't matter whether or not it's cloudy out, you're still getting that UVA rays, especially, and UVB, because you can't tell that it's there because it's invisible to you. Those are pieces of data that sometimes convince people. And then the other thing to remember is that probably what doesn't work. I think it's important to remember what doesn't work. And pushing against someone who is absolutely adamant that they are right, that there's no problem, is probably never going to work, and it's just going to make you angry. So those are the cases where it's probably best to leave well enough alone.
I know we do have many more questions coming in, but we do have two more sections. I want to make sure we're staying relatively on time. We could always circle back around, and I have a feeling we'll answer some of these other questions in our future section. So I believe we were going to hop over to Julie, and we're going to get into some of the primary prevention overview.
Great, thank you. I hope everyone can hear me okay. I think my microphone is a little ways away, but let me share my screen. Can everyone see that?
Looks good.
Okay, great. But yeah, I'm Julie Dhossche. I'm one of the pediatric dermatologists at OHSU, and so I I'm thankful to Sancy for letting me come talk to you guys about primary prevention of skin cancer. So what we're looking at is trying to prevent disease or injury before it ever occurs. So this is done by preventing exposures to hazards that cause disease or injury, altering unhealthy or unsafe behaviors that lead to that disease or injury, and increasing resistance should the exposure occur. So I think this is near to every dermatologist's heart, trying to prevent skin cancers. What can we do, especially from an early age? So I talk to my patients a lot about this and my parents that I see. So kind of starting, just in general, sun safety habits. Seeking shade, really trying to avoid direct sun between 10 and 12 when those UV rays are the strongest and are coming through the most. Wearing clothing that protects you from the sun is really an excellent way for you to protect yourself. When we're having some exposed skin, using a broad spectrum sunscreen of at least SPF 30 and reapplying every 2 hours, even on cloudy days if you're outside. Using extra caution near water, snow, and sand, because these are surfaces that reflect the sun's damaging rays. And so when you're doing those outdoor activities, being careful, extra careful in that regard. And then getting vitamin D safely through a healthy diet. I'll talk a little bit more about this because this is a frequent question I get. For children specifically, so young babies cannot tell you if they're feeling hot, if they're getting sunburned, and so all infants really need to be kept out of direct sun and covered by protective clothing. Finding or creating shade, especially during those peak sun hours. And if sun exposure is unavoidable, taking care to apply sunscreen to exposed areas, so spreading it evenly over uncovered skin, including the ears and lips, really avoiding the eyelids to avoid getting it in the eyes and it stinging. Sunscreens are used in infants older than 6 months old. That's the official AAP recommendation, so American Academy of Pediatrics. If you are taking your baby out, using a physical blocker for any exposed skin, so that means a titanium dioxide or zinc oxide based sunscreen, and I'll talk a little bit more about that. And really these kinds of sunscreens are also best for kids with sensitive and eczema prone skin. Sunscreen sprays, I get a lot of questions about this too, because a lot of people like them. They can be easier to apply, but they're usually chemical based, and you have to be careful because they can be harder to get an even application, and then you have to think about the inhalation risk, especially for children as well. Like I said, sun protective clothing, I love it. I think it's great. And I think a lot of these brands are getting more stylish every year. So this is clothing that has ultraviolet protection factor. So it has UV blocking sort of in the fabric. And don't forget hats. We like them to be broad rimmed so that they protect your ears and the back of your neck as well. And don't forget sunglasses that have UV protection. Same for kids. There are lots of brands that have kids-specific lines. Some of them Some examples include Sunday afternoons in Coulee Bar. There's also a bunch of sunglasses made specifically for kids, can be nice as well. And Sancy included this picture because this is of her son. And I think we just want to drive home that, you know, the earlier to start with sort of teaching these sun protective factors. Like we said, the damage is cumulative as far as that UV damage to your skin cells. So starting early on and instilling those habits is really great. And so this is Sancy's son fishing at a young age, and he still does a lot of fishing and still wears a lot of photoprotective clothing, which is great. When we're talking about sunscreens, which ones do we pick? There's so many out there. You want to make sure that it's broad spectrum so that it has both UVA and UVB protection, and it will say that on the label. We want things, you know, we prefer water resistant. There's no sunscreen that's waterproof. You're always going to have to reapply after swimming or sweating. But the more resistant, kind of maybe the better it will stay on. We want SPF 30 or more. The reason for that, look at the top right chart. So if you have 30 SPF, that means about 97% of the UV dose is filtered out by the sunscreen. Once you get higher than that, benefit is still there, but it's, you know, by 1 or 2%. So I think, you know, what does it say? 50 is about 98%. So you may consider that, especially if you've had a history of skin cancer. And then we like mineral sunscreens the most, I would say. These are ones that contain zinc oxide or titanium dioxide, and I'll explain why that is. So frequently asked questions, what's the difference between mineral and chemical sunscreens? Why are they different? So mineral, also called physical blockers or sometimes inorganic blockers. So this is zinc oxide and titanium dioxide. And once you put them on your skin, they lay on top of the skin and act like a shield to deflect the sun's rays. So the UV rays hit your skin and they bounce off because of the presence of these mineral blockers.
Hi, Tia Kelly is on this call, but
in contrast, a chemical sunscreen, also called sometimes organic sunscreens because they are carbon-based. This includes avobenzone, oxybenzone, octisalate, and there are several more. There's a whole list, so I can include all of them. But these essentially, when you put them on your skin, they absorb into the top layer, and then when the UV rays come in, they act like a sponge and soak those UV rays up before they can cause DNA damage to your cells. Another frequently asked question, I promised I'd get back to this. So what about vitamin D? Don't you need sunlight to get that? Yes, true that some of your vitamin D is made when sun hits your skin, but there are really no studies that show that daily sunscreen leads to vitamin D insufficiency. So the evidence isn't quite there. And you can easily get enough vitamin D from your diet and, if needed, supplements. So I've included pictures of 3 common foods that contain a lot of vitamin D: salmon, eggs, especially the yolk, and then mushrooms, surprisingly, also have a lot of vitamin D. And, you know, given the benefits of sunscreen and photoprotection and the life-saving by avoiding skin cancer, we continue to recommend, you know, using sunscreen and sun protection. One thing I also get asked is about sunscreens and coral reefs. You guys might have heard about this, but coral reef bleaching is something that's seen in some of the high tourist areas like Hawaii and Australia. And, you know, this is likely due to several different factors, but there's been some concern about specifically oxybenzone and octinizate being contributors. How conclusive and convincing the evidence is does remain disputed. And that's because of, the studies are kind of small. They've been done in the lab with high concentrations, and can you really, transfer that to real world conditions? So that's a little controversial still, but, you may consider a mineral blocker, which we prefer in the first place, and or photoprotective clothing instead. Okay, how to apply sunscreen. So this is important. If you found a sunscreen that you like, you want to get the most out of it. So applying a sunscreen before you go outdoors. So for chemical sunscreens, that should be 15 minutes before you go out to give them the chance to work, to do that absorption and protect you. Whereas a mineral blocker, you can put on, you're good to go. Applying sunscreen to all the skin not covered by clothing, and then applying enough sunscreen. This is a common issue. So adults need 1 ounce, which is about the size of a shot glass, or 2 tablespoons to cover their entire body. And that's for the head alone, that's about 1/3 to 1/2 teaspoon. And ideally, reapplying every 2 hours if you're outside, especially for chemical sunscreens, because they wear out. So once they've absorbed a lot of the UV rays, they're no longer active. So it's important to reapply them for that reason. Dr. Leachman gave me some of her favorite sunscreens, which we've included, and some of mine align with this. Everyone's a little bit different, but these are all mineral blockers. So Neutrogena Pure and Free, Blue Lizard Baby, Coats Mineral. So I think a lot of people remember mineral sunscreens from a while ago, and they were all white and really thick, and you could see them like on your face. But more recently, there's a lot of clear and tinted options, and they include vehicles that make them more spreadable and easier to apply. So Coats Mineral, is one of those that's a little easier to apply, and it's got a tinted option. So some people may like that, but remember, if it is tinted, that tint also can come off on your beach towel. Dermatone, Sancy was telling me this is something that she has liked for people that are going out and doing a lot of outdoor activities like skiing and snowboarding. It's a transparent zinc. It's a little thicker, but also prevents against windburn, so that can be a good option. And then Elta MD is a pretty popular brand, especially with dermatologists. They're mineral blockers, and they've got a lot of different lines, including for sensitive skin and things like acne-prone skin, etc. Some ones specific for children that I've recommended. So again, Blue Lizard, Baby Mineral, Neutrogena Baby. There's Avana Cream, which is a line that's especially targeted towards people with sensitive skin, including eczema and other types of dermatitis. And then Badger Sunscreen is a popular one as well. I did include a spray sunscreen on here just because they are popular, and if that's the one you'll use, then that's your sunscreen. This is one that has zinc oxide, the LTMD UV Aero. Most of the sprays are chemicals, but this is one that does have a mineral ingredient. And then remembering that the best sunscreen is the one you'll use. So everyone is different in what they prefer as far as vehicle and texture and color, if they like tint. And skin types are different. So if you have more sensitive skin, remember that those physical mineral blockers will likely be less irritating to your skin. If you have acne-prone skin, there are sunscreens out there just for you. They say, non-comedogenic, which means they don't block your pores. You can find those and use those in areas of your body where you tend to break out. If you have a darker skin tone, there are tinted, clear options that don't have a chalky finish. There will be sunscreens out for you. And I included pictures here of some of my my friends and colleagues' favorite sunscreen. So you can see there's a lot of, everyone has a little, a preference on which ones that they'll wear. So Elta MD, Black Girl sunscreen for skin of color tends to be a popular one, as well as Super Goop matte screen. So it you know, comes on matte, so it's not as shiny. And then some other ones here. So I think that's all that I have. Thank you so much for listening.
Thanks a lot, Julie. We will get into our second raffle here. Just to play off of what she said of being more stylish. I'm not the best at Vanna White, but I might be more sun safe at least. This is the hat that we're raffling off, kind of a wild style, and I can't really do it with my headphones on, but either way, we'll get this working here. So again, we have 5 hats, and we have a small gift bag of sunscreens and a large gift bag of sunscreens. Drum roll, please. Allie Kirby.
Woo-hoo!
I'm assuming Aya or Aha Baycraft. Either way, you're a winner, even if I'm not a winner in describing your name. Francis Lovelace, 3rd winner of our hats. Tim Duncan, another winner of our hats. Last hat winner is Ellen Lippman. Congrats to you guys, as 5 on the hats. I shouldn't say our hats. They're Columbia hats. Columbia has a ton of great UPF options, as well as these hats that they donated to us. So we are on to our small gift bag. Coletta Beckner, congratulations on the small gift bag. That is going to be difficult to give out. So you can send us an email if that's you at warmelanoma@ohsu.edu. Otherwise, I'm going to choose another choice. Sharon O'Brien, the winner of our large gift bag. All righty. So I think we'll jump into our second Q&A section on our primary prevention. One of the first questions that we had was submitted beforehand. And it said, increased risk of skin cancer for immunosuppressed people due to other medical conditions. What preventative or diagnostic measures can be recommended, including vitamins or other supplements for people who are at very high risk of skin cancer due to immunosuppression?
Well, I'm going to jump in. Julie, feel free to jump in too. And I noticed that Liz Berry's also on the chat, and so Liz, also feel free to jump in if you want. But I would say immunosuppression is a real problem, and it's a greater problem in people who have that vulnerability already to skin cancer in the first place. People who have more fair skin, more lighter eyes, lighter hair. Freckles, red hair, those things, if you have those and you're immunosuppressed because of a transplant or some other medicine that you have to take or something like that, or a disease, it doesn't matter. It puts you at even higher risk because, of course, it's your immune system that is surveying all of your body all of the time and getting rid of those cancer cells as they happen. And so if the surveillance goes down, then you have a much higher chance of one of those cancer cells really taking off and growing out of control and really getting to be a problem. So I think that I'm not sure. Can you repeat exactly what the question was that they wanted about immunosuppression?
It was really just looking for what preventative measures could be recommended on top of what you would normally recommend for the general public.
Well, so I think that you really do need to talk to your doctor about it a bit, but I think that in people who are immunosuppressed, one of the things that's come out in the recently is especially for non-melanoma skin cancer. Now, realize that this has not been proven for melanoma, but for non-melanoma skin cancer, there's been some really good prospective trials that have shown that nicotinamide, 500 milligrams twice a day, does seem to really reduce the number of precancers that you're developing, and the idea is, and then that leads to less squamous cell carcinoma. That it hasn't been proven as much for melanoma, and we still don't know exactly what nicotinamide does for melanoma, but it's believed that for the non-melanoma cancers, that's really helpful, and that's in addition to what you're doing. Of course, protecting yourself from the sun is really, really important, and clothing probably works better for people than sunscreen, and so I really encourage photoprotective clothing for people who have that ultra high risk. Anything else that you guys think of in particular that you recommend for your, well, there's one other drug that sometimes is used in people like that that's a chemoprevention sort of agent, which is a retinoid. A form of a retinoid like Accutane is one of those that can also help, but those obviously have to be prescribed by a prescriber. They have to be monitored. They can cause side effects, and you don't go to that until you've really developed quite a few of these squamous cell carcinomas.
Alrighty, we had a few other ones in the chat. Two that were kind of similar. I think one asked if blue light causes skin damage. Using blue light sunglasses is common for us these days in front of screens so often. And the question was whether that would be either preventing or causing face damage. And another question is if household LED light bulbs would emit harmful UV light.
That's a really difficult question to ask for two main reasons. The first reason is that you really need to have a UV detector, a little device that detects UV to know in any given light whether or not there's any UV that's being emitted. And to make a sort of a generalization on that, I think is probably not a good idea, but I believe that there's very little UV in most LED lights, and most screens also have very little UV light that's coming from it. The second reason that it's difficult to but that's why it's difficult to answer that question, but I don't think people should get so worried about the amount that you're getting from that. It's probably not going to be enough to substantially increase your risk relative to walking outside. But I do think that it's very difficult to know about blue light for sure. We don't believe it doesn't have the same level of direct DNA damage that UVB does, but then we used to believe that UVA didn't cause DNA damage either. And what we found is that there's a thing called the dark damage that actually allows UVA to cause DNA damage as well. And so I think there's still enough that we don't know about visible light to make a definitive comment that it doesn't cause any problems. I just don't feel comfortable saying that because I don't think we really know completely what visible light does, but it certainly is not anywhere near as dramatic of an effect as UV light.
I don't think I could have said it any better, and that's my understanding too, is that, there's some small studies that, yeah, maybe, blue light has a little bit of exposure there, but we're not really sure how much it is and how harmful that is. And so we don't really have a great evidence as far as that goes.
I did want to get to another question. We got several submitted questions that was sort of related to the cosmetic side of sunscreen, as well as, the order of application with sunscreen and moisturizer and makeup, or having to reapply sunscreen throughout the day for people who do wear makeup. I wonder if you guys could speak to that, at least, at a base level, at least from your perspective.
Sure. Sure. So first of all, makeup, think about it. Makeup has pigment in it. If it's completely covering your skin, it's probably a great sunscreen. They just may not have done an SPF reading on it. So makeup actually is a really good sunscreen probably on its own if it's thick enough. The idea is if you put sunscreen on underneath and then makeup on top, that really adds an extra layer of protection to that sunscreen that you're getting below. In terms of reapplying when you have makeup on, it probably is easier to reapply the makeup on top than it would be to reapply sunscreen on top. So you put the makeup on bottom, then the makeup on top, or the sunscreen on bottom, the makeup on top, and then reapply makeup to make it a little bit more protective. I think that works for most people. If you don't wear makeup, then reapplying the sunscreen is going to be important, especially if you're outside. You need to do that, what we say is about every couple of hours because it does wear off. And so that's kind of the rule of thumb, I think, for me and what I tell my patients. What about you guys? Julie? Liz?
Yeah, I mean, all sunscreens are tested just on their own, so it's really hard to say exactly how much SPF you're getting if you apply it on top of a product. I think my general rule of thumb is if it's a chemical-based sunscreen, then you should apply it first so that it is sort of on the skin and going to do and absorbing there and going to provide you with the sun protection that it's advertised to do. I think, yeah, physical blocker is a little bit harder. I think anywhere in the layering, it will probably do what it's meant to do. But I don't know that we have like 100% evidence like which layering is the best.
And the last question here that just came in terms of, we know that with water and snow, things can be, you know, they can really amplify the sun's rays by bouncing off of it. The question in the chat was asking if household surfaces like wood floors, you know, walls, things where you may have a lot of different lights going around, does the UV radiation reflect off of that, potentially even, you know, making it stronger or, you know, being at risk in terms of just having those ambient lights that are getting onto you?
Well, UV light, okay, so you have to think about UV light, you know, we call them photons. They're little energy packets, right? And they bounce off of things, right? And so the more light that's coming, so anytime it's hitting something and you're able to see it, it's reflecting back at least to your eyes, right? That's what allows you to see that there's something there, is that the light is reflecting back. And UV light also bounces back, but it has a little different wavelength, so it bounces off with a different curve in a way. But anytime you have the light that's coming from directly above and it hits something directly, that's the most intensity, that's the most energy it's going to have. Once it hits something and it reflects back to you, most of it is not, you know, it varies depending on the surface as to how much of it's being reflected back. So if you see something that's really bright white like snow, right, there's a lot of light coming back from snow, whereas if you look on water is not, it's reflective, but it's not as reflective as the snow. And so there's less light being reflected back from water, but you definitely are seeing that glare. You're seeing something coming back too. So it's never as much as the direct hit that you've got, but it can be quite an amplifier. So you would be getting not only the direct, but you'd also be getting plus whatever is coming back from the reflection of whatever surface. And that actually does amplify it quite a bit, you know, and I think it depends so much on the specifics of the geography and the reflective surface. To give you a percentage is also really hard, but, you know, when it comes to snow and skiing, that can be pretty high. That's why people can get snow blindness, right, because that's enough light that's just coming from the snow to do that for you, even if they're wearing a hat.
Okay, I think we're pretty much right on time here. We're gonna get into our secondary prevention talk, Sancy. So if you wanted to cue that up whenever you want, this is sort of
Sure.
Dr. Leachman's bread and butter here. She could give a 3-hour presentation on each of these topics, but we'll get the real important stuff here.
Let's see. I don't know why this is. Okay, wait. I'm going to stop sharing a minute. Okay, I'm going to pull up my. There we go. Now. All right. Go down to secondary prevention. Current slide. Okay, can you see?
Looks great.
Slide? Good. Okay, so we're on the home stretch, guys. We're on the home stretch. So the boot camp, we started with the facts and figures. Then we moved into the primary prevention, right? How do you stop melanoma from happening in the first place? And now what we're going to talk about is, okay, how do we stop it if you do get it? How do we stop it from killing you, basically? So the definition, the formal definition of secondary prevention of skin cancers is the focus of secondary prevention is early disease detection, making it possible to prevent the worsening of the disease and the emergence of symptoms, or to minimize the complications and limit the disabilities before the disease becomes severe. So we're going to talk now about early detection of skin cancers. There we go. So the first thing is that different people have different risks of getting skin cancer. So anybody can get it. It doesn't matter race, creed, ethnicity, skin color, anybody can get a melanoma. But there are certain traits that we talked about earlier that are known that really do increase your risk. So everyone should know about what those are, because that tells them about, it informs them about themselves and the people that they know and love. So there's both, and we talked a little bit about genetic and behavioral factors. So let's talk a little bit more about this. So this is a table that shows what the risk factor is. I think my laser pointer disappeared. There we go. Okay, so this shows what the risk factor is, and this shows what the relative risk of having that factor causes, what the relative, so the relative risk, what that means, they call it relative risk, because it means relative to the general population. So it's how many times higher chance there is that you're going to get a melanoma if you have that risk factor, right? So if you're a member of one of those families that I showed you earlier in the facts and figures section, if you're a member of one of those families, your chances of getting a melanoma in your lifetime is 35 to 70-fold higher than the general population. That's huge. That's almost 100%. And in fact, in Australia, if you live in Australia, it's over 90% chance that you're going to get it if you carry a P16 mutation. So very, very high risk. If you've had a previous primary melanoma, that's sort of proven that you have both the genetic makeup and the environmental exposures that have created that perfect storm on your skin to make you able to have a melanoma. And if you've had one, then your level of risk is 8.5 times greater than would have been predicted before you got a melanoma, okay? If you have a family history, now this is talking about just having one family member or one, maybe a couple of distant relatives, not like that big family that I showed you. If you have just a single family member that has had melanoma, then it puts you at risk of 2 to 3-fold higher than you would have been if you didn't have a family member. And that's an effect of the genetics and all the vulnerabilities that may have been passed down to you through that family. If you have skin type 1, which means that you always burn when you go out for longer than 30, 45 minutes, and you never really tan very darkly, then you have about a 1.4 higher risk for getting a melanoma just because of the color of your skin. If you have freckling, blue eyes, or red hair, those are all around a 2-fold higher risk unless it's true red, in which case it's up to about 4, and I mentioned that before. If you've had, what about blistering sunburns? If you've had a severe sunburn that caused blistering, that a single one of those will increase your risk 2 to 3-fold over your lifetime of getting a melanoma. And if you have multiple moles or multiple atypical kind of funny looking moles on your body, that can cause an increase of between 2 and 12. And so it's on a spectrum. It depends on how many more you have, you know, and how atypical they look. But it can be a quite substantial increase as well. And now I want to ask you guys a question. Out of all of these risk factors that I just reviewed, which one of those can you change? Are there any one of those that you can change by your behavior? Anything? The only one, okay, I'm going to answer it. The only one is the sunburn history, and that goes back to Julie's point about photoprotection. It's the one thing that is in your control to do to make a difference in your risk. So this is really fun. So we've got a campaign called the War on Melanoma. I hope everybody has, I know most of the people who are on this event heard about this through the War on Melanoma, so you know about it, but I'm not sure that all of you have gone to our website. It's called the Start Seeing Melanoma. It's the lay campaign that we're promoting out across the entire state. And on it, if you want to find out what your personal risk is, you can take this quiz. We have a quiz on that website. It takes, I don't know, 10 minutes or something to take it, and it will give you what your personal risk is based on answering a series of questions like your eye color and your hair color and your skin tone and things like that. So what should everyone be doing, right? And this is part of our Start Seeing Melanoma campaign as well. And I think that you can see the answer is pretty easy. Look. Everyone should be looking for skin cancer to catch it as early as possible. And you need to check your skin, right? It's not just a matter of looking casually. It's really checking all parts of your skin. And so one of the things that I want to reinforce with everybody is how you do a skin cancer. And so I'm going to ask another question for everybody to think about. The majority of skin cancers are first detected by whom? Whom? It's actually the majority, 70% of melanomas. Now, I don't know about all skin cancers because, like we said, we can't track those as well. But for melanomas, 70% of melanomas are detected by either the patient themselves or a family member or friend, not the doctor. And that goes to show that really where we need to go to influence people to catch more is to the individual. To help increase this awareness that they need to be catching their own skin cancers. I don't know. I think I'm going to decline that. The other thing that we know is that if you are doing a self-skin exam, a partner exam is way better than a self-exam because you can't see your back very well, you can't see your scalp very well, you can't see your genital area very well, you can't see even, it's hard to look at the bottom of your feet, but your partner can help you and you can help them. That's a much better exam. And we usually recommend that you do one of these exams once a month. And what I say is think about something that you do once a month. Do you have a bridge game that you play once a month? Do you, do you have an evening out with your friends that you do once a month? Do you pay your mortgage once a month? What is a thing that can trigger you to remember that you associate your skin exam with that so you don't forget it once a month? If you look more than once a month, there's a pretty good chance that you're not going to notice that something's changing as much as you would at 1 month. But who's to know? I mean, it's hard to say exactly what the timing is, but you certainly don't want to wait longer than 1 month, because if you wait longer than 1 month, then it could be farther progressed than you need it to be. Okay. Let's Come on. Okay, so what to look for. So here's the things that you're going to look for. These are the spots. So you can look at asymmetry, border irregularity, color, diameter, and evolution, and that's the ABCDEs. So most of the spots on your skin, completely normal, nothing to worry about, not malignant, completely benign. But if you were to go through the ABCDEs and look at these 4 lesions, I think it's pretty clear which one is asymmetric. This one doesn't have symmetry. It has border irregularity. It has multiple colors. It has a fairly large diameter. It's hard to tell because there's no ruler, but you can tell that it's fairly large. And it's probably evolving because there's a part of it that seems like it's growing differently than the rest, right? The other way of identifying a bad spot on your skin is by looking at what looks different. We call that the ugly duckling. So if you have moles that most people make moles that look pretty similar. They all have sort of similar features. And then if one springs up that's different than the rest, or there's one on your body that looks different than the rest, not just springing up, but changes or something to look differently than the rest, that's a problem. So those are the ones that you're going to be looking for. So these are the ABCDEs. I just went through those. These are the new lesions. You also look for something new if part of the mole looks different than the rest, or if it's a different type of mole. So focus on different and ABCDEs. And this is how you look. We have these this information all on our website, both our Start Seeing Melanoma website and our War on Melanoma website, if you want to really get into doing the best possible self-skin exam you can. But the point is, you do it all over your body, right? You check your face, you check your scalp, you check your parts of your, the places that you don't usually see. Look under your arms, on your breasts, on your back, bottoms of the feet, buttocks. Everywhere needs to basically be checked. Every surface of the skin could potentially have a hidden skin cancer. So what do you do? I mean, the thing is, what do you do if you find something? Well, it doesn't do us any good whatsoever if you've, looked to see and then checked your skin and now you don't do anything about it, right? The key is you need to be empowered. And my goal for this there's one take-home message that I have for you guys is, please, if you see something, do something. It's just like the TSA, right? If you see something, do something. And it's not, oh, it's probably nothing, denial. It's, wow, I should get that mole checked out. And you can get it checked out you can start with a friend, and a friend can give you some opinions, but really the best place to go if you're worried is a provider. And sometimes the dermatologist is one of those providers that you could use too. So the other things that you can do if, let's say, you don't have a provider. Well, nowadays there's a lot of e-visits around. You can do a virtual visit. You can do an at-home skin cancer check with electronically with MyChart or whatever. And we even have now, if you're interested, one of the topics that we had previously was on the Splip, which is a dermoscopy device that you can clip onto your phone. And we have a loaner program so that you can send a dermoscopy photo by an e-visit if you want. So the point I'm trying to get here to, we're trying to make it impossible to have the excuse that you can't get in to see a provider. We're making it as easy as possible to get everybody access that we possibly can. We also have other tools, right? We have a mole mapper tracking app so that you say, well, I can't really follow my moles that well. I can take a picture, but I can't really tell if it's gotten bigger or not. Well, we have a tracking app called Mole Mapper. If you have an iPhone, you can use Mole Mapper to track it. And information about that's on the website too, all of these things. You say, well, I really want to learn more. I want to know what a melanoma looks like. I want some more pictures like what you showed to teach me what is concerning and not. We have a melanoma early detection curriculum that you can go on, and part of that is to just see good spots and bad spots over and over and over again, and you guys can learn that. We also have, a melanoma community registry, right? So that is a place where everyone can come and be a part of pushing the frontiers of research forward and to get involved in helping us put out the good messages, be involved in the war on melanoma in any way that your special talents can help us. We're up for that. You're going to start seeing some social media that's coming out that's educating people more about early detection and looking better. And we also have a new imaging center here at OHSU that has it's got a new kind of detection device, right? It's called in vivo confocal microscopy. And what it is it's so cool the way that science is helping us here, because it's a handheld device, kind of like a dermatoscope, but you put it on the surface of the skin and it will shine the light down and reflect it back like a microscope. And you can see at the cellular level, not quite as good as you could if you cut the skin out and put it on a microscope slide, but it's getting there. And you have a lot more information to help you decide if something is safe to leave and monitor or if something needs to be biopsied that day. So there we go. Let's go to the raffle prize number 3, and I'm going to stop sharing and turn it back over to Patrick before we do the questions.
Thank you, Sancy. I'm definitely guilty with many of these risk factors, so I got to look the part here if I'm going to tell other people to look the part. We will be raffling off 5 more hats as well as another sunscreen gift bag before we go into some questions and start to wrap up. You guys know the drill by now. First winner for our hat is Amy Wood. Second winner, JL. I have a feeling that may be one of our providers, so I'm gonna do another one, but we'll make sure JL gets one if it's not who I think it is. Ron Bloom, the second winner of our Columbia hat. No guarantee you'll look as good as me, but you'll be protected from the sun at least. Cindy, third winner for the hat. Linda Wayner, congrats. Jeff Stevens, another winner of a Columbia hat. And then we have, I believe, our last sunscreen gift bag. Really, drum roll, please. Bea Cox, congrats to everybody here. I'll go ahead and stop sharing and we'll get into some of our questions. The first question that was submitted beforehand, there were several questions that were submitted that sort of surrounded genetic testing. So this one says, who or what clinical scenarios should consider getting genetic testing, or just speaking about special considerations for, people that have these genetic predispositions and having that testing be an option?
Yeah, actually, we have some guidelines on that, and we're in the process. I'm actually working, Liz Berry and I are working with an international consortium called the Genetic Melanoma International Melanoma Genetic Consortium, or whatever. It's a really a good group of people that are exactly interested in that issue. And it's been a while since the guidelines have been established. So we're redoing those. But currently, the guidelines say that if you have, it's sort of a rule of 3s. So we think about it in terms of pre-test probability. What is the probability before you have the test that your genetic test might be positive? Because if it's less than 5% or less than 10%, you probably don't want to do the test, because it's pretty expensive, and you may not want to have the test if it's such a low probability that there's nothing that can be identified. And so we use the rule of 3s to identify people who have a high enough probability to warrant getting the test. And that's usually 3 melanomas, invasive melanomas, in a single individual. Okay, so if a person has had, and that happens with these families, right? They get multiple melanomas. So when you get to the point of having 3, then you need to think about it. If you have 3 melanomas in first and second degree relatives, so a melanoma in a mother, a daughter, and a father, or a mother, a daughter, and a brother, or something like that, right? You don't, it's on the same side of the family. I said that in a confusing way. So a granddad, a mother, and a son, or something like that. It's where you've got 3 or more that are closely related. The third one is whether you have melanoma plus other cancers, like the pancreatic cancer that I talked about, or the ocular melanoma that I talked about, or the renal cell cancer that I talked about. When you have 3 or more of those, it's a little trickier, and that's why the guidelines are being developed. But those are, that's also a rule of 3s. So if you only have 1 melanoma or 2 melanomas, or if you have melanoma in situ, right? Melanoma in situ doesn't count because it hasn't proven itself to be an invasive melanoma yet. So they don't really count towards the count of 3. So that's kind of that's the rules. I hope that makes sense. If that doesn't make sense, just let me know. We can send you the paper.
Great. We had another question that was related to using tanning beds and whether or not using it 1 to 5 times would give you the same amount of risk of using it, maybe many more, 50 to 100. I think it's a relative risk question based off of tanning bed use.
Yeah, it definitely does. The more tanning salon times you've used it, the worse it is for you. And so just think about it this way. It's this energy. It's all physics, right? It's really all physics. The more rays that you've been exposed to, the more damage you've had, statistically, the more likelihood there is that you've damaged a really important piece of DNA that's controlling the growth of your cells. So more is always worse, yes.
This wasn't as much of a question, but I think it's still good to just touch upon very quickly. It's just emphasizing that other skin cancers, including squamous cell and Merkel and other skin cancers that can also be deadly.
Yeah, it's really interesting about Merkel cell. I'm glad somebody brought that up because it looks like Merkel cell, it's not only caused by polyoma virus. Is one of the ways that Merkel cell can be caused is by a viral infection that really gets in there and starts to mess up the control of the DNA. But there's also a form of Merkel cell that looks to be caused by UV light as well. And it's higher incidence in people who have had that sun exposure. So just a FYI, and it's deadly as well. It's a lot, fortunately, much more rare than melanoma, but it is also one of the more deadly skin cancers.
Here's a quick question about, is there any amount of quote unquote safe sun exposure, being out in the sun without sunscreen, and whether or not, aging play into that risk factor with otherwise good sun protection behavior?
So I don't know. I mean, I feel like I want Julie to answer this as well. I feel like I'm kind of jumping in too frequently, but I do have a strong opinion about this one, is that I think that, and you said it, I think you said it really well, Patrick, is that the goal is not to become a hermit inside and never go out in the sun, because our life needs to be worth living, and being outdoors and being in the sun is really, it's one of life's pleasures. I mean, it's a real pleasure. To deny yourself of that would be to really, I think, miss out on a really important part of life. The key is that you can do things that allow you to not get overexposed. And truly, the worst thing is to get burned. Right? I don't think that I mean, if you get into the habit of putting on your sunscreen every morning before you go out and all that, and then, but you don't reapply in the middle of the day and you walk across the parking lot to get into your car, and maybe you go to the grocery store and walk across a big parking lot to get into the grocery store, it's probably not going to be so bad, right? I mean, I think it's putting, you don't want to do anything in the extreme, I think, because that makes you more, it's giving the fact that you've had a skin cancer more power than it deserves, right? What you want to do is you want to be in control. You want to do the right thing that's reasonable in your life, but you want to do it in balance with what makes you happy on a daily basis as well. You can't be so worried about what might happen in the future that you don't live in the moment either. And so it's always a balance, and we're not vampires in dermatology, but we want everybody to be smart and use that noggin and do it the right way. That's okay, I'm done. Julie, you say what you want to say.
I agree. I mean, I think there are a lot of things in life where, you know, you kind of have to measure your risk and decide what you're okay with and how you want to live your life. And I think, you know, we've presented a lot of options as far as what is photo protection, what can you do, especially if you're planning to spend the day outside and have a lot of sun exposure. But I mean, I agree with Sancy, like, I also wouldn't let it control your life and keep you from doing things that you love to do, but do it in a smart way.
The one other thing I saw there in that question that neither one of us addressed is the question about, like, so there's a lot of primary care providers that you may have had tell you, oh, go out and get 10 minutes of light for vitamin D or whatever. And I think that you really need to use good common sense on that, right? If 10 minutes at the time of day when you go out is enough to burn you, that's a problem. That's not good advice for you, right? If it's not, you know, if you have more darkly pigmented skin and 10 minutes is fine and you never get any sort of sense that there's anything that's going wrong and whatever, and your doctor thinks that that's a better way, maybe you can't take vitamin D3 by mouth, or maybe you're not eating enough dairy, or, you know, who knows what. I wouldn't go against it because, you know, and yet I do also believe that why would you get unnecessary exposure if you can get it orally? And we know that there doesn't appear to be any difference in the metabolism of vitamin D, whether you get it via the sun or you get it orally. So anyway, I think those are all questions, but use common sense that applies to you, right? Tailor those pieces of advice to you and your skin type.
Well, this is perfect. We'll just take credit for it ending perfectly on time, like we practiced it 100 times. Before we did go, I want to say a few things. Not only thank you to everyone that has joined us. We hope this was really valuable for you. Congrats to those who have won things. We did have some support to be able to do that, which is here. So thank you to Moda Health, Columbia, Elta MD, as well as there were some questions we didn't get to and some questions that were a little bit out of scope as far as this talk, but I wanted to plug that we do have 2 more of these conversations, these virtual meetups that are happening this summer. The next one is June 15th. That's more specifically towards what it means, you know, to get surgery of any kind for a skin cancer. And one in July that's focused on our new advanced imaging technology that we have here to do virtual biopsies. Both members of the melanoma program will be joining us to go over that. And if you want to register for those, you can do it the same way that you did for this one. You can go to warmelanoma.com and you can go to our events page, and we'll be promoting these separately as well. But otherwise, I think that is all from our neck of the woods. We appreciate it, everybody.
Thanks. It was fun. Thanks for coming.
I feel like I need to go to the beach now.
Thank you. Thank you.
Ready for it, Patrick, so.
I know, right? I have to go rub the sunscreen in before it gets stuck here.
I just purchased over $200 in sunscreen for my family. Thank you, guys.
Great. Thanks for coming.
Oh yes, and I can definitely send out a sort of a summation email to everyone that registered with the PowerPoint, at least slides in PDF form, as well as some of the links to some of the things that we talked about. It's also going to be recorded, so watch it again on your lazy Sundays, share it with your friends, that sort of stuff.
Thanks very much.